Hi, my name is Pooja Gohal, lead navigator at Can Do Health, and I'm here to share about Principal Illness Navigation, the new billable codes that reimburse these services, how Can Do has been a pioneer in the implementation of the codes, and how your programs could use them too. My aim for this presentation is to explain the guidelines for PIN codes and how they can benefit patients, hospital care teams, and payers in improving outcomes and reducing healthcare utilization. So what are PIN codes and how do they work? These codes are the first and only codes established this past January 2024 by the Center for Medicare Services that reimburse for what is called navigation. Navigation support is intended to help close the existing gap in care that occurs upon discharge home. It is required for an advanced care practitioner to initiate the program by what is called an E&M visit in order to determine if the patient will benefit from navigation services. During that E&M visit, there's an opportunity to bill for the assessment of social determinants of health as well. The care plan that's established from this initiating visit is carried out by the assigned navigator, who can then bill for the 60 and 30-minute codes. The current reimbursement as of today is listed on the slide. Here are the guidelines that would qualify someone for PIN services. A few things I'd like to highlight are that the program must be delivered in an outpatient setting, in person or virtually. Patients must have a serious medical condition. In our case at Can Do, a stroke, and that condition must be expected to last for at least 3 months with a high risk of readmission, death, deterioration, or admission to a skilled nursing facility. The best part is that it can be delivered for up to 1 year following the prescription of the services, which we know is much needed since recovery is a longer journey than just the first 90 days. Additional guidelines to keep in mind is that a minimum of 60 minutes of navigation work must be completed monthly in order to bill for the codes. Navigation can be a combination of live calls or other asynchronous work. PIN codes don't conflict if patients are receiving home health services or outpatient therapy. They can also be participating in other concurrent care management programs or remote patient monitoring with no interference with PIN services and billing. Lastly, if someone has multiple health conditions, such as cancer, stroke, addiction, that patient can receive separate PIN services for each qualifying condition without conflict for billing. Here's a higher level look at the components of PIN services. I'll be walking through each one with specific examples shortly. Let's take a look at how Can Do has approached PIN services in the post-acute stroke population. As soon as someone is discharging, our Can Do liaisons or the hospital stroke coordinators identify eligible folks for the program and get them registered. Our Can Do team specialists will first connect with them over the phone and set them up for that initiating E&M visit. And once they've passed that, then schedule them with their navigator for the onboarding call. The main things I'd point out about this program outline is the oversight we provide in the first 90 days of their stroke. We maintain close communication with the referral hospital system to relay the 30 and 90-day modified Rankin scores. We also begin addressing mental health needs early on and address their SDOH needs as well. The first 2 calls are the most dense in delivery of programmatic elements, and then the communication fluctuates based on their preference. How do the elements of PIN support stroke patient outcomes? Let's meet Mr. Singh over here. He is starting his post-stroke journey with so many directions he could go in, and unsure where to start. The hospital's nurse navigator helped him navigate their hospital system, and now the PIN services would help him navigate his stroke, ultimately really his life. The Can Do navigator is right behind him to help him steer him in the right direction. Using person-centered assessments allows for the opportunities to identify red flags early on and make an effort to put safety guards in place. Mr. Singh's SDOH needs showed that he needed medication financial assistance, support with hospital bills, DME to address falls, and new mental health needs. Behavioral health needs are prevalent and not easily anticipated. Thus, being able to provide support during these situations is crucial. Taking this extra time up front to conduct these person-centered assessments helps build rapport and normalizes the mental health conversation across various cultures. The impact on the system is that we get them connected to triage processes for emergencies, redirect them to services within their medical homes, and ultimately, the aim is to reduce readmissions. Hospitals are not generally equipped to manage outpatient needs once an individual is discharged. Care coordination for Mr. Singh was helping him apply for an interim health insurance, getting him connected to a local paratransit service, and introducing him to virtual speech therapy and a smoking cessation program. Gaps exist in the transition of care, even in the best systems, which may require triage. Some things are time sensitive and require immediate attention. Supportive services for Mr. Singh was that he was able to have his initiating E&M provider call in a seizure medication into the pharmacy while the navigator was still finding a PCP for him. Or it was helping write a referral for a home health aide since his pregnant wife wasn't able to help him with his showers. The navigator created a safety plan for his suicidal ideations. Mr. Singh came home with a stack of papers from the hospital and unsure on how to make sense of any of it. The navigator helped him break down complex medical terminology and by this, allow them to understand who they are seeing and for what. Properly delivered curated education aims to improve health literacy, encourages self-advocacy, and overall follow-through of discharge recommendations. Health education is delivered based on what they want to learn and how they can best digest it. With the support of the navigator, Mr. Singh learned how to talk to various people in his social systems and knew when and how to escalate his needs. The more people we have advocating for their needs and knowing how to navigate the systems they have access to, the hope is that less likely people are to overdepend on the emergency department to solve their non-emergency problems. What we've seen it can do is that hospitals have limited visibility of readmissions that occur outside their system. Our program tracks in detail all readmissions and reports it back to the referring hospital so we can try to solve the root of the problem. The heart of the program is facilitating behavior change. This is where the work is done towards stroke prevention. The navigators use the readiness for change, motivational interviewing, and take charge frameworks when approaching personal lifestyle choices and behaviors. Mr. Singh learned how to identify his triggers for when he craved a cigarette and replace them with healthier behaviors. His navigator helped him explore alternative stress management techniques and connected him to a mental health therapist that understood his South Asian diaspora. Most importantly, the changes that were discussed were small and incremental in order to maintain the lifestyle modifications in the long run. Again, the goal here is to reduce readmissions, stroke occurrences, and continuation of these lifestyle changes. We undermine the power of support, mentorship, and inspiration. Leading with the social connectedness framework, we've seen how it can provide a safe space to share the lived experience component that the navigators cannot and would not try to replace. Mr. Singh regularly attended the virtual support group led by Survivor Can-Do ambassadors that made him realize that he's not alone. Others have overcome all sorts of obstacles and thrived, and renewed sense of motivation and purpose for his recovery journey. Mrs. Singh also took advantage of the care partner resources as well. When PIN is successfully implemented, we've seen that more than 75% of enrollees have returned to living independently by program completion. This is based on the 62% of modified Rankin scores we collected for stroke patients that were referred within 30 days to us of hospital discharge, and among them, over 75% have achieved an MRS score of 0 to 2. We've also achieved more than a 50% decrease in the number of readmissions in the first 90 days post-discharge as compared to the published norms. Currently, our 30-day readmissions are at 2% for patients we've served, compared to the published ranges of close to 9 to 12.5%, and our 90-day readmissions are at 6.5%, compared to a range of 18 to 20% from the published data. We have a net promoter score of 89 plus, which indicates a high satisfaction with our service. As a matter of fact, we have the privilege to hear from one of our stroke survivors and recipients of PIN services here today as we transition into a fireside segment.